Well, that was our talk for laparoscopic liver surgery. We're going to change gears a little bit now and move on to the pancreas. So I'm going to spend some time, and my talk's going to be a little bit more different. I'm going to try to go more of a technical talk and talk about laparoscopic left pancreatectomy, and then Dr. Merchant will follow with pancreatic head resections, and really the most important aspect of that operation, if you're going to proceed with that operation, is achieving that negative surgical margin. So again, I'm at Charlotte, North Carolina, at Carolina's Medical Center. And as we know, there's a large role for laparoscopy in pancreatic surgery. And you can see a number of the utilizations that we have for laparoscopic surgery at this time. And there are a number of indications for laparoscopic pancreatic surgery, as you can see. And probably the most common reason, I would say nowadays, particularly doing left-sided pancreatectomies, it seems to be the increased either prevalence or awareness of pancreatic cystic neoplasms or pancreatic cystic lesions. And there is a wide variety of pathologies that we need to deal with, and oftentimes the challenges for us is to be able to distinguish one pathology from another preoperatively so we can determine the most appropriate treatment plan for those individual patients. But when it comes specifically to pancreatic cystic neoplasms, basically, as we all know, there are two main categories, serous lesions and mucinous lesions, and it's really the mucinous lesions that the ones that we focus our efforts on. When it comes to serous lesions, serous adenomas, or the old language microcystic lesions, again, sometimes they can be a little bit difficult to diagnose, particularly if they're small. But again, I think we can all understand and agree that for smaller lesions that are asymptomatic, that we can prove that they're serous lesions, that the malignant potential is almost zero, and then most likely we could follow those lesions. When they become larger, as you can see here, or symptomatic, then those would probably be fairly standard indications for resectional therapy. When it comes to mucinous lesions, again, usually radiographically they appear different under CT, MR, as well as endoscopic ultrasound, and there are some tests that we can do to help try to differentiate lesions that are mucinous. And again, there's a variety of pathologies, including mucinous cystadenomas, mucinous cystadenocarcinomas, IPMNs, side branch IPMNs, but they all fall within the same general category. Again, you can see radiographically how they appear. They're usually unilocular, thin-walled cystic lesions, and again, can have a variety of endoscopic ultrasonographic findings. Now, when it comes to mucinous cystic lesions, there's a wide variety of opinions regarding which can be followed and which can be resected, and I'll kind of leave that out for a debate later. What I want to really focus my talk on tonight is how to walk through a laparoscopic left pancreatectomy. And when it comes to left